Welcome to our channel AMC Learner. Today the topic of our discussion will be palpitations. As you can see on your screens, chapter number 59 of John Murtak. First of all, we need to know what are palpitation. Palpitation is racing of the heart basically. You just have to give a read to the key facts and checkpoints. Moving on to the next page, nothing important. Then do give a read of red flags for palpitations, as they do come as an MCQ point. Moving on, just give a quick read to the examination, nothing important. Regarding figure 59.2, there are various pulse form and the diseases which cause these type of pulse form. You have to remember this table for the AMC exam. Just give a quick read to the figure 59.3. Moving on to the palpitation in children and elderly, we will be discussing this but in the future pages. Arrhythmias, give a read to the facts and figures, nothing important. Now on page 17-20, these figures are of prime importance. The first figure is normal sinus rhythm. The second one belongs to sinus bradycardia. As you can see, the heart rate is below 60. It is 55 beats per minute in this picture. Moving to the next picture, it is sinus tachycardia. Heart rate is above 100 beats per minute, which is sinus tachycardia. Next is complete heart block. Complete heart block, there is prolonged PR interval and there is skipping of a beat, as you can see. Moving to the next is the picture of the atrial flutter, which is really irregular. Next picture is of atrial fibrillation. Moving to the next picture, which is of premature complexes, which is none of importance. Moving to the third last picture, which is supraventricular tachycardia. These are the pictures which do come in the exam. Next is ventricular tachycardia, and the last one is the ventricular fibrillation picture. Next pages are not of importance. Moving to the topic known as supraventricular tachycardia. Supraventricular tachycardia is basically paroxysmal or sustained when the heart rate is between 160 to 220 beats per minute. There is copious amount of urine produced in these patients. Probably this is due to EV nodal re-entry or due to the accessory pathway known as WPW syndrome. So in WPW syndrome, there is basically skipping of the AV node. The accessory pathway bypass the AV node. This is shown on ECG with a typical short PR interval and upstroke of QRS complex known as delta wave. These 2 points favor towards WPW syndrome. The characteristic feature that differentiate WPW syndrome is that in this we manage WPW with flecainide, procainamide. We cannot use sutalol, amiodarone, these type of drugs, as these are contraindicated in WPW syndrome. Moving to the management of supraventricular tachycardia. Always remember, in supraventricular tachycardia, paroxysmal supraventricular tachycardia more precisely, carotid sinus massage is the treatment of choice. Valsalva maneuver, but it was the treatment of choice, but in new guideline, carotid sinus massage is now obsolete, and Valsalva maneuver is the first choice of treatment. In children, we perform modified Valsalva maneuver. In infants, immersing the face of the patient in the cold water is the treatment first line. If in patient all the vagal stimulation fails, the next step is adenosine. We can repeat adenosine 3 times. If patient has asthma, we have to avoid adenosine as it can cause bronchospasm. So in patient of asthma, we prefer to give verapamil. For the prevention or maintenance, for the prevention of frequent episodes, first line is beta blockers or calcium channel blocker. Then we can add flecainide, but the most appropriate would be radiofrequency ablation, which is usually most curative. This is all about SVT. Next is the important one is atrial fibrillation. For atrial fibrillation, just give a quick read to it, all of the atrial fibrillation, the facts and the figures. But the things to remember are that they have a similar risk factors as of thromboembolism, and the underlying cause include myocardial ischemia, thyrotoxicosis, hypertension, mitral valve disease. Sometimes MCQ do come from this topic. Moving to the next is atrial flutter. In atrial flutter, there is sawtooth appearance of the wave, and there is always, almost in 90% of the cases, there is history of hypertension in case of atrial flutter. So we have to give patient anticoagulation in this case. So anticoagulation is required in case of valvular atrial fibrillation. According to the CHAD score, we prescribe patient with DUAX or warfarin or factor Xa inhibitors. Now moving on to the rate control. In rate control, remember metoprolol is a drug of choice. It is preferred over the propranolol. So metoprolol would be the drug of choice in case of the rate control. And for next is our table, which is really important. All the points we will be covering in this table. Now in this table, sinus tachycardia. If patient has sinus tachycardia, the first line is treat the underlying cause. Maybe the patient is on caffeine, so we have to reduce the caffeine intake. The second line would be something to control the rate. So the rate controller medicines like calcium channel blocker and beta blockers, and in beta blockers metoprolol is the choice. Moving to the next is bradycardia. If patient has 6 sinus syndrome, we have to give him permanent pacemaker. If patient has AV block, we have to further divide it into the first degree, second degree or third degree AV block. In first degree AV block, no treatment is required, as there is a gradual prolonging of the PR interval. In second degree, it is further divided into Mobitz type 1 and Mobitz type 2. In Mobitz type 1, there is gradual prolonging of the PR interval and ultimately a beat is missed. This is known as Mobitz type 1, second degree heart block. In this, no treatment is required. In Mobitz type 2, there is missed heartbeat, but there is no gradual prolonging of the PR interval. So in this, we have to advise patient to have a pacemaker insertion. In third degree heart block, we have to divide it, either it is acute or chronic. Basically in third degree heart block, there is no connection between the atria and the ventricles, so we have to give patient pacemaker. In second line there is adrenaline, and in third line there is atropine. Next are paroxysmal supraventricular tachycardia. As we have discussed before, Valsalva maneuver is nowadays a treatment of choice. Carotid sinus massage is obsolete now. So if we have to divide the patient, if patient is hemodynamically stable, unstable, or if he doesn't have any pulse, there are 3 type of cases. If patient is unstable, if patient is hemodynamically unstable, we have to do DC cardioversion. If patient is pulseless, we have to do CPR. If patient is hemodynamically stable, then first of all go for the Valsalva maneuver, followed by adenosine, IV or verapamil, and the third line would be DC cardioversion. Next would be atrial fibrillation or atrial flutter. In atrial fibrillation or atrial flutter, first of all we have to control the rate, and then we have to control the rhythm. To control the rate, we prescribe patient with beta blocker or calcium channel blocker. To control the rhythm, we give DC cardioversion. Same rule applies. If the patient is hemodynamically unstable, go for cardioversion. If patient is pulseless, go for CPR. If patient is stable, then control the rate and the rhythm. In the next step, we add digoxin, or we do cardioversion with some drugs like sotalol, flecainide, procainamide, or we prescribe some anticoagulation. And third line would be electrical or chemical cardioversion, or would be permanent AV node ablation or permanent pacemaker. Next important is VT, ventricular tachycardia. Either it is non-sustained or sustained. We have to divide it accordingly, and we have to prescribe patient with beta blocker to control the rate or amiodarone, and drugs if patient is stable for cardioversion. If patient is not stable, then go for DC shot. Next line, second line would be lignocaine IV, and third line would be DC cardioversion. Next is ventricular fibrillation. Ventricular fibrillation, it is really irregular, and we have to give DC cardioversion first, followed by adrenaline and then amiodarone. This table is really important. Just learn it by heart. All the MCQs from this topic mostly come from this. Just remember all of these with their ECGs. And one more important point, that if patient is hemodynamically unstable, we go for DC cardioversion. If patient is pulseless, we do CPR. If patient do not recover, we again do CPR. After 2 attempts of chest compression, then we give patient IV adrenaline. And in case of SVT, we can give adenosine 3 times. Thank you so much for listening our lecture. Thank you.